All right, so here we are, powered by Iron Health Podcast. This is episode relaunch number 2, and we are here with Ryan. I want to say it, Chevrier. Is it French?
It's very French. Guess what it means?
To walk.
No, not even close. It means goat herder.
Have you chased your descendants to actually be goat herders?
No, I have not. But there's a goat cheese brand named Chevrier.
Oh, really?
Yeah.
That's a fun fact for our listeners here.
Yeah, that's true.
All right, so today we are going to be talking about ACLs. This is going to be the biggest kind of overall arching thing of this podcast. Ryan right now is the ACL expert, and he's also our director in our Briarcliff location, so we brought him on. We're going to talk a little bit about his story, and then we'll get into ACL specific. It's a big population of what we see, and I think it's kind of sometimes mistreated, and the severity of it is huge, right? What did you say?
Yeah, especially the last 2 years. I mean, what I'm seeing now, percentage of my caseload compared to what I was even 3 years ago, is night and day, which is fun because it's exciting, but it's also pretty sad.
Yeah.
It's real sad when you think about it.
How many of them are repeat?
So I unfortunately have 3 repeat right now. I know, but all contact, which is the one thing that you can't control in the office, which honestly makes it a little bit more devastating, a little bit harder to accept, especially when it first happens, because you spend months and months and months with them, but then they go out and they play, and it's the only thing you can't control, no matter how hard you try. So you feel a little helpless when it happens.
Yeah, and we could circle back around on that too, on the psychology of ACL, because that's huge. It's a huge component of the rehab.
That could be its own podcast.
Yeah. All right, but before we dive into that, let's talk about you and your story. Why did you become a PT? And then let's hear your story on how you came on board with Iron Health. How many years now? 4?
October will be 4.
Wow.
Went real quick.
It's wild.
It's over half my career.
Crazy.
Yeah. So my story into PT, I do not have the conventional, I got hurt, helped me get back to my sport. When I grew up in a small town, a farming town, and if you got hurt, it was pretty much rub some dirt on it. So I never went to PT, didn't even have friends who went to PT. I was sitting in my room, I was a junior in high school, and I was like, what the hell am I going to do with my life? And I started Googling some occupations. I really liked athletic training because I loved playing sports, so I was like, let me stay in that athletic population. And then I started looking into that more, and I was like, okay, well, they don't get paid that much. They sacrifice a ton of time at night. Real hard to have a family like that. And I just didn't want to be tied to that night-only environment. So I started looking for things that were similar, and I kind of landed on physical therapy and orthopedic surgeon. And then I started diving back into those a little bit, and I was like, do I really want to spend 12 years of my life doing residencies and training and med school? And I was like, no, absolutely not. So I was like, all right, PT it is. And then I applied to PT only accelerated 6-year programs, and I got in, and I just never looked back.
Oh, wow.
It is not the career path choice that I would suggest, just blindly picking something because you think you like it. Yeah. But it's worked out, so I guess I can't really complain about it that much.
Yeah, I mean, you got lucky at that point.
I know. I got very lucky that I still enjoy what I do.
What 6 years did you do?
So it was 3 years undergrad.
Okay.
That I did at St. Thomas Aquinas, and then it was 3 years of grad school at New York Med.
How did you do that? Because So I have a backstory too, where my college actually said they did the same thing, but then I went to grad school and they were like, no, we don't have that program. It actually doesn't exist.
You got screwed.
I got screwed.
So mine existed. Mine was a little tricky. So I technically didn't graduate from undergrad. I went 3 years undergrad, had to apply, do all the interview stuff. Thankfully didn't have to take the GREs. And then I went to grad school. And what I had to wait for was 2 years of grad transfers or credits to transfer back to my undergrad, to graduate with my undergraduate degree, and then finish out grad school. So my diploma is technically, I got my undergrad in 2015 and then my doctorate in 2016.
Oh, wow.
So on paper, it makes absolutely no sense.
Well, you got lucky.
I know.
Did you know that school had that? You went to New York Med?
I did, yeah. So I only applied to schools, and I looked into both, made sure. So of the 3 I applied to, one couldn't give me information on it. So I was like, see you later. The other one had information, but when I talked to some of the students in it, it was real tricky. And just because you got a spot in that accelerated program didn't mean you were automatically into PT school and that fast-tracked 3 years. So I was like, well, that defeats the whole purpose.
Yeah.
And then St. Thomas Aquinas and the New York Med connection was the only one that, as long as I followed the steps, I had to take extra credits 2 semesters. You just went straight through.
Wow.
And I had to interview and get in, but
yeah. So you did some good research.
Yeah.
My point, I didn't do that much research. I just saw it on paper and I took it and I was like, but that's the kind of person I am, right?
Risk taker.
Yeah. So, but
And
it cost me a year of my life.
Yeah.
So,
right.
how would you recommend people doing it the way you did it?
If you know what you want to do, I would, absolutely.
Yeah.
It's a year of your life, especially with how expensive school is now.
Yeah.
100%. Save the year.
Yeah, I agree. And you have, how old are you now? So this is a good thing. Ryan runs our Briarcliff office, which has been in business 5 years almost. We're moving to a bigger, beautiful location.
Brand new, bougie.
Yeah, bougie. We'll have pictures coming up next. And he is how old?
I am 29.
29. Not even 30 years old yet. And he has 2 kids and a wife and a house. And
I know.
he's got a 70-year-old soul.
I'm going to retire at 50.
That's your goal?
Maybe 45.
No, they can't leave.
Heads up, just so you know.
I got to be retired before then.
All right, you can. You can go at 35, Marie at 40. I'll go 45.
All right, so that's it for all the young pups there. You know our schedule, so you can kick in and take over at that point. That's pretty wild, though. You're not even 30. 2 kids, house, director of an office.
I know. And my wife just turned 30, and she's in the same boat.
It's awesome.
Teaching 7 years, 2 kids, house. It went real quick.
Yeah, time flies. In general, it's just scary. I'm sure you see with your kids now. They're walking, talking, running.
I mean, my almost 1-year-old turns 1 in 3 weeks, and I feel like we just brought him home. Makes no sense.
It's
and
life.
then a 3-year-old, I don't even want to talk about that.
Yeah.
I don't know how that happens.
It goes faster the older we get, too, right? Because it's just relative at that point. Like your life distances.
I remember sitting with you at River Outpost and telling you that we were pregnant with our first kid.
Yeah.
And I can remember the whole thing.
So crazy.
And that was almost 4 years ago at this point.
Yeah, what is the story for our listeners about how we met? Because we have an interesting past.
Yeah.
Like me, you, and Maria all went to New York Med.
Yeah. Known each other forever.
Yeah, we've always been in each other's lives for a long time now. It's kind of wild.
So Joe, I actually turned down the very first time I met him.
Turned me down.
I was just out of school, and I interviewed with him at his last place before he opened Iron Health, and had a job offer, and I didn't like it, so I said no. Very loosely kept in touch with you, and then I was actually on my honeymoon, and I decided I was going to leave my last job while we were on there, and I told my wife as soon as we get back I'll send some resumes out. And while we were there, you actually messaged me on Facebook asking if I was looking for a job.
Oh, wow.
Yeah, I don't know if you knew that. So
I forgot.
Yeah, I'd already decided, and then you messaged me before we even had the chance. So it was like we were destined to cross paths again.
Yeah, that's so wild. I forgot I messaged you. I must have been in the mode where I'm like, all right, I gotta find these people.
It could have been
3
years earlier because Maria spelled my name wrong.
Yeah, that's true. That's true.
Can't ever let her forget about that.
We can. I'm gonna put it on podcast so she hears it later about spelling your name wrong.
As we're sitting at her house making fun of her.
Yeah, that's funny. And then the rest is history. We met and came on board, and
it's
been growth ever since.
I know, a lot of growth.
Yeah,
a lot of growth.
And very different too. I mean, I would say, obviously, you're in a different position, right? Like where you are in a leadership role. How would you say the company is to you, and what really makes us different? Like that's a good point before we dive into ACLs.
Yeah, I mean, honestly, what really makes us different is I don't think people understand the amount of time we spend talking about the growth of everyone in the business, and because we sometimes make quick decisions, I think on the outside it seems kind of very like we're not putting thought into it, but everything is very calculated.
Mm-hmm.
More so than I ever thought it was. But there are no quick decisions without any thought or conversation. Everything is planned out, both company-wise and personally for the rest of the employees.
Yeah. I feel like that's
Which is
evolved
neat.
too, though.
Yeah,
for sure.
it definitely has, especially the last 2 years.
Yeah, I mean, that's something that I personally want to work on too, because it's important. Like, I'm a quick start, I'll just go. So I'm glad that I can just say something and then Maria or you could just shut me down. So it's good to have that balance.
I feel like I'm the tiebreaker vote a lot of times. You're saying yes, Maria's saying no, and then both of you are like, tell her yes, no, tell him no. It's fun. It's a fun position to be in.
That's good to know. It's good to leverage that. So let's get into some ACLs. This is what this convo is about. I know it's always good to get some background and people to get to know us, because that's going to be important. But let's talk basics of ACLs. Mostly, let's start how they happen. Who do you see them happen in? What age group? What demographic? And kind of the trends you're seeing right now before we dive into the specifics of rehab.
Yeah, so what we're seeing now in the office is the overwhelming majority are adolescent females, 13 to 18. I would say, so we currently have in the office 12 patients post-op ACL.
Wow.
Yeah, I mean, we see maybe 160 visits a week, and I would say at least 40 of those are ACL currently. It's a huge, huge group that we're seeing. But the most of them are that adolescent female population. And I think what's happening is they're playing more, they're playing harder, they're playing faster, and they're playing with, going back to playing more, they're playing on all these different teams.
Mm-hmm.
So they're time playing the actual sport has increased tenfold in the last 10 years.
What sport are you seeing? Is it mostly soccer?
It's soccer and basketball.
So crazy.
Yeah, I would say 9 out of every 10 I see is female soccer and basketball.
Yeah, and it's mostly contact or non-contact?
Mostly contact that I've seen, which to me is a good thing and a bad thing. It's a good thing because it means that there wasn't any inherent weakness that really led to it on their end, so you can focus more on strength instead of their actual positioning. But it's also a bad thing because the emotional aspect and the psychological aspect, because sometimes there isn't anything they could have done to prevent it.
Yeah.
They could have just been tackled from behind, not even seen it coming, and then the pressure caused them to tear it.
That's interesting, though, that you're seeing, or at least we're the case study of one, right? And the fact that you're seeing more contact is interesting, because what's really changing to be more contact injuries? You think it's just time under tension?
Yeah, I think it's just they're playing more and they're playing harder and faster. But it is interesting. So I've been out 6 years now from school. My first 3, I would say almost every single one was non-contact. Mm-hmm. Now the majority is definitely contact. You still get the occasional cleat stuck in the turf, but a ton of them have contact involved.
Is there ways to prevent that?
The short answer, no. There's ways you could work on it, especially challenging. They're finding a big connection between the eyes and the vestibular system, but it's still hard to train. You can get a certain type of speed in the clinic and even in practice, but game speed is completely different. It's so hard to work on.
Yeah.
It's just about controlling when they get back, but even that's not a perfect.
Yeah, because that's a tough one, right? Because non-contact can technically have pre-exercises or strength training to help prevent that. But if you're seeing just specifically contact, is there going to be a new research that says, hey, if you really work on this, you could prevent your ability to have contact injuries? I haven't seen any of that.
I haven't either, because it's usually all lumped together, unfortunately, still.
Yeah.
So the ACL tears as a whole, you can reduce the injury risk. But I haven't seen anything where they differentiate between contact and non-contact.
Okay.
I'm sure it's out there, but what scale and how accurate it is, I haven't seen.
Well, I think if they're addressing it as the whole, that's probably pretty good in general, because it is taking into account
definitely
both.
A good start.
So if we're seeing preventative measures as a whole, that should be something that should be more adopted, especially for high school girls, right? They're going through a lot of changes, puberty. That's going to change the way their body reacts and the way their tissues 100%. Are going. If we had a perfect world, what would be the training protocol for these girls prior to any injury, or their coaches should be introducing to their program?
The easiest one, just because it's standardized and it has plenty of research around it, is FIFA 10. And it doesn't take that much time, so your ability to stay consistent with it is higher. It's just 5-10 minutes, 10 exercises that you can just rattle through at the beginning. So in a perfect world, everybody would be doing that beforehand.
Okay.
Or at least a modified version of it.
Okay, and we could attach something here maybe to the podcast, to the notes on the bottom about FIFA 10. Because
Yeah.
I don't even think I've heard of that. So what's the premise?
It's just a group of exercises, and I think they chose them based on like what clinicians were doing, but it's just what they have found is that if you do these before, you can lower your risk. I don't remember the percentage, but it's decent enough that the 10 minutes you spend doing it to lower your risk is worth its weight in gold.
Yeah, of course.
None of it's hard. None of it requires that much equipment because they're doing it out on the field. So it's pretty easy to stay consistent with it.
Yeah,
That's the big word, is staying consistent.
Well, that's easy. It should be easy. That should be standard.
Yeah, it should be.
It should be standard.
It's not, unfortunately.
What do you say to people who would say to brace the kids, like put them in knee braces at that age range?
Without an injury, I would not, because you become reliant on that brace and dependent on that brace, and you're just going to become weaker in the end.
Yeah.
They're finding that after the injury as well, because you can lower some of the fear with putting a brace on when you return post-op. But then once you take it off, you go in this crazy like psychosocial state where you're afraid again.
Mm-hmm.
So now you're back playing at a higher level, and then you remove the brace, and then your body's like, oh crap, like I don't know if I can do this without it, and you just set yourself up to get hurt again.
That's interesting.
There's a lot of debate currently on like post-op bracing when you return to sport.
What about immediately post-op?
There's still some debate on that. We have two right now who came in, no brace post-op.
Specific surgeon, I think I know who it is. So
yeah,
it's the same surgeon. Yeah.
So but two completely different. Yeah, 100%. Two completely different circumstances.
Yeah.
I think everything. I mean, just like with everything else in the world, everything has its place. It's just what's the best option for this individual, not like just the blanket. I'm going to throw a brace on you. You're going to do these exercises.
Yeah.
It's looking at everything involved in it.
Yeah, you're completely right, and it's tough because when you're talking about the general, you have to talk in big concepts.
Yeah.
But you're right. Every single person should be assessed differently and looked at in a specific way.
I mean, think of how many different graft options there are.
Yeah.
And then if you have meniscus involvement, no meniscus involvement, iliotibial tendinosis, which we're seeing a lot more in the office.
Yeah. So we could jump.
Modified Lemaires.
Let's jump right into that. Let's jump because now we talk prehab. Let's go into the specifics of surgery as far as what are you seeing? What do you traditionally like? And what do you think has the best outcomes? Or what's new, too? There's a lot of new, like you're saying. New ones.
So, I mean, the traditional is bone, patella tendon, bone. There are so many surgeons around here that's what they've been doing for years, that they just default right to that. What we're seeing a little bit more of in the office here now is quad tendon, especially with the adolescent female. So what's happening is their patella tendons aren't actually big enough, so they can't take them.
Oh, wow.
So they're coming and taking the quad tendon. And what we're also seeing in some of the younger groups is either a iliotibial tendinosis to help tighten the lateral outside of the knee, or a Lemaires or modified Lemaires, which just helps provide more internal support as well.
So what are they doing in that one? Let's get specific.
I don't actually know what the specific one is, because, and I probably should, but I've seen it written where some of them say they're doing the Lemaires, but they're only doing the tendinosis. Okay. So I don't even think they know.
Are they doing that on kids who growth plates aren't efficiently grown yet? Because that's different as well.
Yeah, so two of them I've seen, there's no way they're done growing. They're 13, so there's absolutely no way. So they're doing
usually you'll see the Lemaires on...
I've seen the Lemaires on either re-tear, and they're trying to just provide support because your chance on either side goes up, and now if you've had two, your chance on either leg is even higher, so they're just tightening it to make sure. And then I'm seeing it on some of the younger, really young adolescent females to make sure that it doesn't happen again.
Gotcha. Are you seeing any hamstrings in young kids or no?
I have not. The last time I saw a hamstring was 3 years ago, and she was low 50s, which was interesting in its own right.
Yeah, I wonder if they're even doing them for kids.
Yeah, I probably wouldn't want them doing it on kids anyway.
What's your rationale?
Especially because we see a lot of females, and I know there's some debate on quad hamstring ratio, but don't touch the hamstrings. When they're there to help provide support, the anterior translation, I just would not touch them. I would not weaken them any further than you have to.
Yeah, I agree to that. It's a
Yeah.
fair assumption of that. The quad tendon one's an interesting one too. What are they taking? Like a third of it, the front, the medial third.
It depends on who they are. So some of them, because it depends on size when they open them up. Some of them are going vertical, and some of them are going horizontal to get enough like width of the tendon and enough length out of it.
Are they taking a piece of the patella?
No.
So it's just a straight graft,
just
no
straight
bone.
graft tendon.
Yeah. So that's why I guess a lot of them are opting out of that too, because the bone seems to be a better plug, right? Where your body can.
Oh yeah, 100%. Bone into bone.
Yeah.
And then I think it just holds better with the anchors.
Yeah.
I mean, I'm not a surgeon, so I can't actually attest to that, but
yeah,
in theory it would.
Totally. And when we talk about surgery, right, there's so much more avenues that can go down that's like out of our scope. This is just us briefly discussing what is going on with that.
Back in action.
Yeah. I had a patella graft.
I always forget you had yours done.
Yeah, and disclaimer of it, I don't think it would ever be the same. I don't think it's ever been the same. And now I have a lot of issues up my kinetic chain on that leg. And I don't know if it was necessarily my rehab or what the situation was. I really don't know.
How long ago was that even?
Years now.
Yeah, because I mean, even me, I mean, I've been out 6 years, and every single year I change how I approach it, just based on what's coming out of the new information.
Yeah,
like what true. I look back 6 years ago, and I know some of them. I like keep in touch with them, and they haven't had any issues. And I'm like, I feel like I failed you. Like there's so much more I know now that I could have done with you.
Yeah.
And even just there's so much more we know as like a profession that it's like, oh, what did I do with you?
That's a good point.
Yeah, my wife tore hers twice, and her knee is just never the same. Very
same
stiff.
One?
Yeah, same one. And then second time they took the other patella tendon, so which is tricky. I'm not sure how I feel about that either.
Yeah,
we can talk about all this all day.
Yeah, you're getting into another leg that doesn't need anything, and you're going to touch it.
Mm-hmm.
But what do? Do you give a cadaver at that point?
So what we're seeing now is they're going quad tendon on that same leg. They're going to further weaken the one to like preserve the other one.
That's a long rehab at that point.
Yeah,
which is really necessary. You know.
Yeah.
For me, what I notice and something that I bring to my ACLs is always looking at the ankles and the hips. Because I think that's what was missed on me.
100%.
Like my hips are so stiff, my ankles are stiff. If they're not addressed and really treated, and they're only looking at your specific joint, you're not gonna be 100%. There's no way. You're not gonna be 90%. You won't even be 90%.
I mean, it's unfortunate because there are some of the like bigger mills out there where you don't have the time to focus on anything, and there's people that still get that, in my opinion, like inferior treatment.
Yeah.
Whereas like now I just made you buy an inline dynamometer so we can get even more objective measures to track how we're doing and change and individualize to the person. And then there's other people who are still getting cleared based on a resisted straight leg raise. Yeah. It's ridiculous.
It's ridiculous.
It's crazy.
I mean, that we'll dive into this, the return to sport if we get to it today, but that's so true. It's a cookie cutter approach to something that's not cookie cutter, man.
Not at all.
ACL, any rehab is not cookie cutter. I think that's the problem with our industry as a whole. You know, I mean, I don't want to even go down that rabbit hole. That could be a 7 podcast of me going on rants.
I know we could tangent from ACLs very quickly right now.
All right, so let's go back to ACLs. Someone comes to you post-op, day 1. What are you seeing? What are you looking for? What should they expect?
Yeah, so my day 1 is pretty simple. I usually get them on the table, and I tell them that this is going to be like the most boring session you're ever going to have. So when I see you, especially if I didn't see them pre-op, the first thing I'm trying to do is develop a relationship with you. Because even if insurance cuts you off, on the short end, it's 6 months, 2 to 3 times a week. And you are not going to get them to buy in and do everything at home if you do not have a relationship with them. To me, that's the most important and sometimes like most underrated aspect of it. The second thing I'm doing is unwrapping and like just measuring and looking at it. Does it look like it's infected? Has the redness? Has the swelling? I'll measure all of it. I'll start to measure higher up on the quad to see if there's any atrophy. And then I will do some motion. And then to me, the biggest thing is trying to get that quad function back, because the quicker you can get them using that quad again. If there is no meniscus and they can weight bear and walk, the quicker you can kind of get some gait symmetry again, the easier everything will fall into place, and then the more confident they become on it. They start to feel like they're not just what's the word I'm looking for here? Like they're not dependent on their crutches or like a caretaker to help them out. So the quicker you can get all of that to fall into place, the easier the next month is typically. So that's day one for me.
You have them walking day one?
Depends who it is. Sometimes I'll have them walking with the crutch and putting as much on it.
Yeah.
Still locked usually, the brace, because especially if they don't have quad.
Yeah.
But I try to. I think it helps their confidence. It really does.
Yeah.
But if there's meniscus, then absolutely not.
Meniscus repair.
Yeah, repair.
Okay. Which is done less and less, I think.
It is. It's done less and less, but the last few we've had, they're making them wait longer and longer to weight bear.
With an ACL and meniscus repair?
Yeah.
So how long have you seen?
So previously I was seeing 4 to 6 weeks. Now I'm seeing 6 to 8 weeks.
Wow.
Which, yeah. I thought I just shut that off.
No, it's a long.
Which is a long time. That's 2 months.
I want to see some research on that coming out. Like, what's the caveat of that? Why are you doing that?
The answer every time I've called is to protect the graft and protect the repair. That's it.
The
That's all I've
meniscus
got.
repair.
Yeah.
Yeah, I mean, that's...
The last two, I've spoken to the surgeons, and that was the rationale. Almost like verbatim from each other. Which, it's their surgery, it's their repair. Can't argue too much with it.
Yeah.
But, on our end, when we're seeing them 3 times a week and they're seeing them once every 4 weeks, it's tough to help kind of get that buy-in.
Yeah, get buy-in, and honestly, they're going to be delayed in the next couple of weeks, in a couple months maybe. Honestly, let's be real.
I think it's
meniscus
setting it
repair.
back a month.
Yeah,
honestly,
at least.
Yeah,
at least, because weight bearing is everything. That quad's not going to come firing. The psychosocial aspect, you're not going to have the muscle-mind connection.
Mm-hmm.
Meniscus repair could be a whole talk too.
I know.
Because I don't even know.
This is going to be like 7 podcasts.
Matt's writing down the list, so we can have for the next episode, next couple of months. Day one, you looking at extension? Because I've always look at that.
I am, yeah. So I usually look at it both before stim, and then I'll usually measure before stim, and then I'll look again after stim to see what it looks like. But to me, they should come in with like full 0 extension, because then you never want to lose it. And then I know if they're not doing their stuff at home because they've lost it.
Yeah, that's a fair point. Extension's so important.
Yeah.
There's so many restrictions in that.
I sometimes won't look at flexion day one, especially those who haven't seen it. They've never had a surgery. They can be pretty emotional when you take that bandage off and they see the scar, and then the flexion is what's going to hurt. So if I know I'm seeing them within the next day, because I try to see them back-to-back days so I can get measurements, get the quad, and then the next day get in and actually start like treatment. So sometimes I'll save the bending for day 2 because it's not worth it. I'd rather sit there and talk to them honestly while they're on stim and get that quad back and just develop a relationship so that we can be friends and get more buy-in for the next 6 months.
Yeah, no, that's a really good point. Rapport building is everything, right?
Yeah.
We forget sometimes as therapists like how vulnerable you are after surgery, but because we see it all the time, so we normalize it. But to them, it's everything. It's something that, as a PT in general, like if you can't have these conversations with people or understand that you are there to help them get through, that's a big factor. That's a part of our job, especially like with us in Iron Health. That's
I
huge.
think a good PT who can talk to people great is better than a great PT who can't talk to people at all. Especially in our setting, a one-on-one setting, like you're 40 minutes with someone. If you can't talk to them, it's going to be a long shift.
Yeah.
We probably wouldn't hire you.
Yeah. You probably wouldn't want to work here.
Yeah.
That too.
But I think that's more important sometimes.
Yeah, I agree. Phase 1 then, so what are you doing? That's the first day. What still encompasses your phase 1 of treatment?
Yeah, so my phase 1 it can be anywhere from like 2 to 6 weeks depending on what else is involved. But it's flexion to at least 90, full extension. If you are allowed to walk, I want walking without a crutch, and brace unlocked or brace off at that point. And even though sometimes people hate this word, but like leg raises without lag. Like it just has to happen. You have to be able to differentiate quad and hip flexor and your rectus working for both.
Mm-hmm. Why do people not like that?
Well, leg raises. I mean,
What are they saying
a lot
on
of the
Reddit?
a lot of the Reddit. A lot of the mill PTs, like you're doing leg raises 3 times 10 for 4 months.
Oh yeah. Okay, I see what you're saying.
So it can be a little taboo in the profession, but
But I mean, ACL,
it's needed.
It's
in
necessary.
Right circumstances. Yeah.
It's a very sophisticated measure actually to know if someone can move to the next level, I would say.
Mm-hmm. Yeah. Well, those are my big things that I look for in the beginning.
And how long do you say that usually takes?
Around 4 to 6 weeks. It's tough because a lot of the protocols are like timeline driven, and then they'll have criteria to pass. To me, like that timeline just needs to go away, and it needs to be all criteria driven. Like one person's going to do it in 2 weeks, and another's going to do it in 6. They're both going to be successful when they graduate PT. But I think we too often get stuck in like, well, I need to be here at 2 weeks. Well, that person might not be ready in 2 weeks to do that.
Yeah. That's a really good point.
Yeah. Like especially with the amount of re-tears we've been seeing, is one might be like the quickest ACL ever, and then all of a sudden the next one you're struggling to get flexion back, and they're thinking, well, like, what am I doing wrong because it came back so quick the first time, when really you're not doing anything wrong. It's just completely different.
Yeah.
The same person, same surgeon, but 2 surgeries are completely different. You can't compare them.
Yeah, that's a solid point. Criteria over time. We should make shirts that say that.
Yeah, criteria.
ACL shirts.
With a little like math logo on it.
Put an Ironhold logo some there.
Yeah.
Trademarked one.
Do it. Matt, write it down.
All right, so after this phase 1 of criteria being hit, where are we going next with these clients?
Next, I'm going on more like functional strength and hypertrophy. By functional, I mean like you have to be able to take care of yourself. Especially, we are seeing a little bit more like older population, like 40 to 60s, getting it done. And like you need to be able to squat. You need to be able to deadlift and pick something up off the floor. It doesn't have to be 800 pounds. And then hypertrophy, like that muscle is going to atrophy the second you go into surgery and have that tourniquet applied. You have to get that back as quick as you can, or at least start working on it. So by then, usually around like 3-4 weeks, I'm throwing on the BFR cuffs, and I have them up, and we're just weight bearing and doing as much exercise as we can. Still working on the motion, because by then we'll be pretty close to full, usually, hopefully. But we'll get to rest, and then we'll kind of reinforce that, and then we'll go out and load and get that muscle growing.
Okay. I love the incorporation of BFR for sure. Has that been a big part of you introducing to ACLs?
It has. So that's one of the things, especially when they can't handle load, or especially when they're non-weight bearing for 6 weeks. Like I look back and I'm like, what did I do from week 3 to 6 with a meniscus repair? I mean, leg raises, even if you had an ankle weight, like that's not enough load to stimulate anything.
Yeah.
BFR has been a huge asset into our post-op rehab. It really has been.
Yeah.
When we took the course, we were all interested, and I'm like, all right, we'll definitely use this. I mean, we're like fighting over the cuffs in our office because we all want to use them.
Yeah, especially, I mean, with that many ACL clients, absolutely. It's necessary.
Yeah.
It really is. It probably accelerates the rehab in that point.
I don't know how you could load efficiently from 4 weeks to 8 weeks. Or if you are, because you can do their endurance probably isn't there yet. So you might be able to load 1 or 2 things efficiently, and then the rest of it to me is almost like fillers. Where if you could load 1 or 2 things moderate, get a good stimulus, they're not going to be able to handle that the entire session. So do a little BFR circuit at the end to focus on hypertrophy after you did some of the strength work.
When do you introduce leg press, that compression load? Regular ACL, no meniscus.
Yeah, honestly, it depends on how they are with squatting, and not even to make sure like the form and the shift. Sometimes they're just very hesitant in that weight-bearing position. So, I mean, I'm going to contradict myself a little bit. Sometimes I won't, because I don't think they're going to be comfortable in that knee bend with the compression. Sometimes I will, because everything looks right, but they're hesitating. And instead of feet planted, moving your body on your feet, I'm going to plant your body on the leg press and move your feet off that. So you're just changing which side's solid, which side's moving. Same stimulus, same movement, same joint mechanics. But you can almost trick the person into doing it and getting in that position.
Yeah.
I would say I usually start at like 6 weeks or so. I don't like to do it earlier. I'd rather get them
it's like
still
end of phase 2.
like that. Yeah.
Yeah. See, I may introduce leg press a little earlier because I actually like the isolation of it. you can do a single leg versus a squat where they can compensate a little bit more.
Yeah.
I do like functionality of a squat. A box squat is ideal. A TRX squat, really get their
TRX
mechanics down.
all day.
Yeah, but a leg press, if a quad don't fire, you're not cheating on that thing. They call that
that's true.
They call
Very
it like
true.
a self-limiting exercise, right? Like Ray Cook always talks about that. Like if your quad's not going to fire, you're not moving that thing.
No, that's very true.
Yeah.
Very true. Especially the ones we have.
But
Can't really cheat on those,
I
actually.
guess the debate really is the compression load, though. Like some people probably, I would say the compression's good, but if you're at a specific angle, maybe it's not. I don't know.
I mean, to me, if you're staying under that person's body weight, like if they're standing and weight bearing and you're doing like single leg TRX stuff at that point, like it's the same compressive forces.
Yeah.
Honestly, you might have more weight on the machine, but the way the pulleys work these days, that's probably less overall like force.
That's a good point.
Don't quote me on that. I don't know if that's
Quote
true,
it,
but
put it in the front of the podcast.
But I don't think it'd do that much. I think people are afraid to load them sometimes.
Yeah.
We just choose different ways to load them.
Yeah. No, that's a good topic of discussion. What do you do? What are you doing now at phase 3? So we went through really the two first phases.
Yeah. So by then we're getting ready to start running. I don't like to run right away. So I know there's like 2 camps. It's run right away or like delay as much as you can. I kind of find myself in the middle. So what I like to do first is work on like landing and like low level, low load, like easy plyometric jumping. And my rationale for that, I forget who I heard it from, but like running essentially is jumping from one leg to the other. So when there's all these other factors and mechanics you can look at in running, I'd rather eliminate all that and make sure they can handle the actual loading first. So I usually do at least 2 weeks of like drop landings, tall stand to like squat landings, things like that, double leg, single leg. And then I'll work on some like band assisted jumps just to get the calf working a little bit more and kind of work on that stretch shortening cycle. Because running also should be pretty efficient. So if you can get all these things kind of working isolated first, then it's not going to be perfect, but then they can handle the load, their calf can kind of handle that quickness and be a little bit more efficient, and then I'll get into running with them.
Yeah, I actually think that's really sound judgment there. It makes sense.
Thanks,
that actually makes a lot of
boss.
sense. I'm going to start incorporating that. I'm with you, though. Like the running to me, well, one, if there's an athlete, they're going to want to run, right? So you got to introduce it. But sometimes I do think it is introduced too early because there's, like exactly like you said, there's so many things that go into running. Jump them first. Drop jumps are so valuable. They have to be really looked at.
I'll usually, because think, if you're dropping onto one leg and you can't control that, and then you try to run, which is jumping from one leg to the other leg, and you can't control, and then you're trying to push off from that, it's just a recipe for disaster.
Yeah.
Obviously, as you run, it'll get better, but just single it out first. But I usually start that around like 3.5 months or so. I really try not to run before 4 months. I kind of like that 4.5-ish. Oh, hello, friend. I didn't want to get up. I'm committed to the podcast.
Blooper number 1. B would have stung him.
But I really try to run somewhere between 4 or 4.5. But I'll introduce jumping as long as their atrophy is or their hypertrophy at that point. If their quads are getting more symmetrical, then I'll start jumping at like 3.5.
Yeah.
Very, very low level. Like we're not doing like 20-inch box jumps, but all the drop landings, things like that.
Again, it's all criteria based too, right? Like I'm with you on that. That's a solid, logical.
A lot of my running and when I'll start comes from Dr. Lynch, who I used to see a lot of his post-op ACLs, and he doesn't want you even considering it until you are 1 centimeter or less average atrophy of your surgical side compared to your non-surgical. So at that point, at 3.5 months, I will quickly measure. I mean, sometimes every session, but at least once a week. Especially when I know we're getting closer, I'll measure and measure and measure. And I'll do it kind of pre-exercise so that no pump can kind of influence that a little bit.
Makes sense. What strength training are you doing in that phase? Or advanced strength training, really?
A lot of single leg. Single leg squats, single leg deads. I'll start working a lot more lateral motions as well. Ton of leg press, deadlift, trap bar. pretty much anything I can get my hands on. Usually that point as well, right? So they're only with us at that point twice a week. That's not enough. So if they don't have access on their own, that's when I'll usually try to push them to a trainer. Nobody can go 7 days a week. You need to recover, especially, you're still 3.5, 4 months after a surgery. But if you can get in twice with me, twice with a sound trainer, it just kind of accelerates that 3 to 6 month period.
Yeah.
And you might not see the results right away, but at that 6 month mark when you're getting ready to start your early baseline return to sport testing, it'll pay off in dividends.
Unicorn cup, cat cup.
Yeah, should we show off our mugs real quick? Thank you, Maria.
That is like my cat, his glasses.
That's you in cat form. You'd probably be an all black cat though.
No, I would want to be one of those big Maine Coons with black eyes.
I kind of like the unicorn. Although it looks like a cow.
Yeah, it's a fake unicorn.
Yeah, all right.
All right, phase 4, ACL.
Back on track.
Return to sport testing at this point. What's your criteria? What are you looking at?
Yeah,
when do you give them that blue check?
In a perfect world, probably never. Because I don't think anyone's ever ready to go back. No. So to me, the big things I look at, so we have our own return to sport testing at Iron Health that we've kind of adopted from a bunch of different places. But we look at the movements on it, but honestly, by then you're anywhere from 8 to 10 months. If someone can't squat and squat jump, you would have never gotten that far. So that's on our thing, but if you're failing that at this point, then honestly you failed the last 4 or 5 months. So what I really like to look at is I like to look at Y balance, mostly to see just how comfortable they feel, and it's a lot of anterior reach is what I really look for. Are you going to load that knee and are you going to load that quad? Do you feel comfortable with it? And I like to see that within 95% of the non-surgical side. And then I look at a ton of different jumping and hopping. So we look at single jump distance, triple jump, crossover hop, 6 meter timed single leg hop, and then I want all of those within 90%. The other thing we're looking at, which we have started to test around 4 months, we actually mentioned it earlier, the inline dynamometer. That already, in my opinion, has paid for itself, is being able to just objectively quantify peak force on one leg compared to peak force on the other. How much can you actually push? And a manual muscle test is not going to do that. So outdated. We used to do a 5 rep max on the leg press, but it's just not consistent enough. And now we have this unit hooked up to your iPad, and we can see. And we were actually pretty astonished on some of the people we did. There was one kid I probably would have passed if we did not have this, and then I put him on that, and there was a 23% deficit.
Wow. So
he was only, what's the math on that, 78%. And I was like, holy moly, you can't do this yet. That's not even close to where you should be. Meanwhile, all his single leg stuff looked phenomenal. He actually looked better on his surgical side. We just needed more time and a lot more single leg work. It only took him a couple weeks to add on to that at his own home. And then, that's really what I'm looking for is the jumping. And then what I'll also do is, which we won't talk about this too much, is there is a good outcome measure. Normally I hate them, but there's one. It's the ACL, Return to Sport Readiness Index. I don't remember the real name, but it pretty much just asks a bunch of questions, very subjective to them, but it's, are you ready to go back? Do you feel comfortable, yes or no? And it's scaled and graded, and I know people want above 90% on that. To me, I want at least 95% on that. If there's still 10% of you that's hesitant, you're going to get hurt again. Because you're not going to give it your all, you're going to hesitate, and they're not going to be ready. So I want at least 95 on that. The rest of them, in a perfect world, I'd want 95%, but at least 90 for all of them. And then what we're actually trying to start testing, which we haven't, and this is where before, the more I practice and the more I see, the more I'm I don't actually know anything, is vertical jump. There was 2 studies that just came out, and they took this group of people, and I don't remember the exact numbers, but they there was a group of post-ops. They all passed their horizontal jumping. Only 70-something% of them passed their vertical jumping. So to me, that's more important than all the horizontal jumping that we're doing, which is all we're doing really. So Anthony and I in the office are coming up with ways that we can start looking at that, because right, we have 12 post-op ACLs in there, all 6 months and under. Like, we're gonna have to start testing that soon. And now, like, to me, now that I know that information, I feel like if I'm not testing that, then I'm doing them a disservice. So I got to figure that out.
Yeah, you got a new office for it.
I know. I'm gonna spend more of your money.
It's our money. It's collective. It's for the people.
For the people, it
We
is
want to
really.
get better. We want to get
Yeah.
better. We want to deliver the best.
That was why we
quality
got the dynamometer.
Yeah, which I think is an amazing add-on.
Yeah, I don't know how I practice without that. We've only had it 2 months now, maybe. And the first day, every single one of us used it, lower body and upper body. And we were like, how did we go this whole time without this?
Yeah.
How did I go 6 years? And I mean, I don't muscle test too much because it's super outdated. But like, how was I not like getting objective info like this?
Yeah. Objectivity is important, right? You don't measure it, it's not really getting better. So that's
exactly,
solid.
yeah.
Cool. All right. So before we wrap this up, any closing thoughts from you? And obviously, I think one thing we'll do is the sports psychology aspect of it's going to be its own podcast. Maybe we'll revisit it. Especially if we get comments and stuff about it. People want to hear it. We'll do that.
Yeah.
But any closing thoughts before we wrap it up?
Yeah. So this was very, very, very like a basic overview. I mean, this is a 10 to 12 month rehab that we only talked about the phases for like 5 minutes. It feels like. My closing thought is that even though we just talked about all of this, it is so individual. We just said what we were doing all the phases. It might be completely different based on your surgery. You cannot take anything for granted, and you can't just go into the cookie cutter approach like you said. Yeah, this was pretty fun. We should do it again sometime.
Yeah, it's fun. All right, well, thanks, Ryan, and everyone out there. Check us out, Powered by Iron Health. We're going to keep doing these, and I hope you like them. Later.
Signing off.